Friends, this is the last topic in respiratory physiology. In the previous videos, we had a thorough understanding of all the basic essential respiratory functions, the mechanisms, the concepts behind all these respiratory events. With the accumulated knowledge in the previous videos, let us explore clinical conditions and how these concepts are getting applied in understanding those clinical conditions. Now, first condition that we will be discussing is hypoxia and its relevant oxygen therapy. So, hypoxia literally means inadequate tissue oxygenation. Ultimately speaking, the peripheral tissues in body is not receiving enough oxygen, doctors. That is the term that we describe as hypoxia. Now, if you look at the pathway with which a tissue receives oxygen, the whole thing starts from atmosphere. From atmosphere, gases moves into airways. From airways, goes to alveoli. Once it reaches alveoli, it is being diffused to pulmonary capillary. Pulmonary capillary fuses to form pulmonary veins. Pulmonary vein carry the blood to left atrium. Left atrium channelizes the blood to left ventricle. From left ventricle, we got aorta that takes the blood to peripheral tissues. Now, aorta branches out into arteries, arterioles, meta-arterioles, capillaries. Finally, it reaches tissues. So, oxygen has to travel a long path before it reaches a tissue. Problem anywhere in these steps will lead to tissue hypoxia. So, you guys know atmospheric pressure, abbreviated as ATM, is going to be 760 millimeters of mercury, out of which partial pressure of oxygen in atmosphere, abbreviated as PATM-O2, is about 149 millimeters of mercury. So, this air is going to get entered into airways. As the air enters into airways, this air that gets into the airways will be very dry and rough, which needs to be moistened and humidified. So, what does airways epithelium do? They add water vapor with a partial pressure of 47 millimeters of mercury. When the incoming air is moistened by addition of water vapor at a partial pressure of 47 millimeters of mercury, the partial pressure of oxygen and other gases is going to get proportionately reduced. So, this leads to reduction in partial pressure of oxygen by the time it reaches alveoli. So, partial pressure of oxygen in alveoli, abbreviated as PAO2, is going to be 102 millimeters of mercury. Fine. Once the venous blood in pulmonary capillary reaches the alveoli, they do have a partial pressure of oxygen at a level of 47 or 40 millimeters of mercury. Partial pressure of oxygen in venous blood is going to be 40 millimeters of mercury. There is a huge pressure gradient, isn't it? You have 1 or 2 millimeters of mercury at alveolus, 40 millimeters of mercury in pulmonary capillaries. The pressure gradient favors transfer of oxygen from alveolus into pulmonary capillary. So, by the time the blood crosses the alveolus, blood gets adequately oxygenated to a pressure of about 102 millimeters of mercury again. So, partial pressure of oxygen in arterial side of pulmonary capillaries will have a partial pressure of 1 or 2 millimeters of mercury. By the time they form pulmonary veins, pulmonary vein is going to receive additional input from bronchial veins. Bronchial veins carrying deoxygenated blood that are collected from pulmonary structures will be emptied into pulmonary vein that should be carrying oxygenated blood. Now, because of venous admixture of oxygenated blood, there is going to be an addition of more carbon dioxide to the oxygenated blood. As a new gas is getting added, partial pressure of existing gas will reduce. So naturally, the partial pressure of 102 millimeters of mercury comes down to just 100 millimeters of mercury by the time it reaches left atrium. So what happens in left atrium, doctors? If you consider the musculature of cardiac structures, heart muscles do get their arterial blood supply from coronary arteries. We all know that. Now, the venous drainage of cardiac musculature happens by Thebesian veins. Thebesian veins are venous channels that drains cardiac musculature and empties the blood into that respective chamber itself. So, Thebesian veins of right atrium empties into right atrium itself. Thebesian vein of left atrium empties into left atrium itself. Thebesian vein of left ventricle empties into left ventricle itself. So, as these Thebesian veins contributes to addition of carbon dioxide, the partial pressure of oxygen will come down even further. So, this leads to fall in partial pressure of oxygen as the time the blood gets into aorta. So, partial pressure of oxygen in aorta will be arterial blood PaO2, arterial blood will be somewhat about 98 millimeters of mercury. 98 millimeters of mercury, doctors. Okay, so what started in atmosphere as 149 millimeters of mercury will be reduced to 102 in alveolus and just 98 or even lesser, 96 in arterial circulation. So this is how the oxygen which is in the arterial blood reaches tissue. So remember, my dear friends, when oxygen gets to a tissue, the partial pressure of oxygen in blood vessels, arterial blood, will be 98 millimeters of mercury. So let us take up hypoxia here. We just discussed that hypoxia is nothing but a poor tissue perfusion. Now, when a tissue receives very under oxygenated blood, it will land up in hypoxia on one hand. On the other hand, if a tissue does not receive blood supply at all, again the tissue will land up in hypoxia. So we have a lot of conditions that puts the tissue into a hypoxic environment. Let us take up the first condition and let us divide the causes into two broad categories, and the first one is normal tissue blood flow. On the other hand, the blood flow is decreased, reduced blood flow. When the blood flow is normal, what can be the causes of hypoxia, doctors? Here the blood flow is absolutely fine, no problem at all, but still the tissue is not getting enough oxygen. So what can be the causes? The causes can be again classified into three conditions. Number one, poor oxygen content in blood. Number two, there is going to be a normal oxygen tension but reduced content. This is going to be quite confusing at the beginning. Be very focused in this topic, doctors. At the first condition, there is going to be poor oxygen content. This means there is going to be a reduction in O2 tension as well. Okay. The third one is normal O2 content but poor utilization. Okay, we'll come to these factors one by one. We discussed in the previous videos that oxygen in blood is being carried by two forms, doctors. Oxygen in blood is being carried by two forms. First one is oxyhemoglobin, by which 97% of oxygen is being transported. Number two, dissolved form, by which 3% of oxygen is being transported. And you know very well, it is this dissolved form of oxygen which is going to contribute to partial pressure of oxygen. So when we speak about partial pressure of arterial oxygen, we are not going to include the oxygen combined with hemoglobin. As we discussed in oxygen transport video, we know that any gas, when it is getting stuffed within a container, an RBC is not going to contribute to partial pressure. So oxyhemoglobin does not contribute to partial pressure, only the dissolved form of hemoglobin is going to contribute to partial pressure, doctors. So in this case, when you consider oxyhemoglobin, the majority way with which oxygen is transported is by oxyhemoglobin form. So together, oxyhemoglobin plus dissolved hemoglobin together forms oxygen content. So when we say, or when we speak about oxygen content of blood, oxygen content of blood is by two forms, and the first form and the majority form is oxyhemoglobin, and the second form and very little amount is dissolved form. Right, doctors? So when there is going to be a reduction in either oxyhemoglobin or dissolved form, there is going to be a fall in oxygen content. You know very well. So this is the formula, isn't it? Oxyhemoglobin plus dissolved form is going to be the oxygen content. So if we have a reduction in oxyhemoglobin or a reduction in dissolved form, in either way there is going to be a reduction in oxygen content, right? So isolated reduction in oxyhemoglobin or isolated reduction in dissolved form or combined reduction in both oxyhemoglobin as well as dissolved form will reduce the oxygen content of arterial blood. Right, doctors? Let us take up the very first condition, poor oxygen content. There is going to be a reduced oxygen content, at the same time there is going to be reduced oxygen tension. So what are they speaking here? There is going to be a reduction in partial pressure of oxygen. This is called as oxygen tension, the form PaO2. The dissolved form, the 3%, is going to be contributing to partial pressure, and that word is represented as oxygen tension. Right, doctors? So reduction in arterial oxygen tension is called as hypoxemia. Reduction in partial pressure of arterial oxygen is called as hypoxemia. So hypoxemia is a very important cause of hypoxia and first and foremost cause of hypoxia, doctors. So let us expand hypoxemia in a separate discussion, but as of now just get to know this. Reduction in arterial oxygen tension leading to reduction in arterial oxygen content is called as hypoxemic hypoxia. So this leads to hypoxemic hypoxia. Fine, let us keep this aside for a brief moment. Let us finish all those smaller events and let us take up the significant one. The second one, normal oxygen tension. Oxygen tension is normal, which means partial pressure of arterial oxygen is normal, but the content is reduced, which means when you have one form normal, doctors, when the dissolved form is normal, but you still have, when the dissolved form is normal, but you still have reduction in arterial oxygen content. What can be the reason? This is absolutely because of reduction in oxyhemoglobin. Reduction in oxyhemoglobin. So the second condition, where you have a normal oxygen tension, reduced oxyhemoglobin, this leads to reduction in oxygen content. When can we have such a kind of presentation? The ultimate mechanism, doctors, clear here, it is due to reduction in oxyhemoglobin. So the reasons are, number one, anemia. When the hemoglobin itself is absent in blood, severe anemia will lead to impairment of oxygenation of RBCs. When RBCs are not getting enough oxygen and the dissolved form is going to be normal, right? It is just going to get dissolved in plasma. That 3% is not going to change, but the 97% is going to be decreased. So together, reduction in hemoglobin leads to reduction in oxygen content of blood. Because oxygen content is impaired, the tissues will get less oxygen, and such a kind of hypoxia is called as anemic hypoxia. So this is not just anemia alone, doctors. When there is a profound methemoglobinemia or sulfhemoglobinemia. Number 4, carbon monoxide poisoning. All these are the reasons for anemic hypoxia, doctors. So anemic hypoxia is manifested by normal oxygen tension of blood but decreased oxygen hemoglobin, and this leads to reduced oxygen content. Okay, this is anemic hypoxia. Now let us take up the third one. Oxygen content is absolutely fine, no problem at all. Look here, there is no problem in oxygen content. It's very normal, but oxygen is very poorly utilized. What does this mean? We have a cell here, and this cell is being adequately supplied with enough oxygen. So here we have 97% of oxyhemoglobin normal, 3% of dissolved oxygen normal. So oxygen delivery to the tissue is absolutely fine, absolutely normal, but the tissues are not utilizing it. What is the condition? We have a poisoning called as cyanide poisoning. Cyanide poisoning blocks mitochondria to utilize oxygen. So in spite of abundance of oxygen in the periphery, in the vicinity of a cell, the cell simply cannot able to take up any oxygen. Now this kind of pathology that contributes to mitochondrial failure is called as cytotoxic hypoxia. The cell is being poisoned with toxins, especially cyanide. Okay, this is also called as histotoxic hypoxia. So the third condition is cytotoxic hypoxia or histotoxic hypoxia, doctors. So we have ruled out three kinds. Number 1 is hypoxic hypoxia, second one is anemic hypoxia, and the third one is cytotoxic or histotoxic hypoxia. Right? The reason for cytotoxic hypoxia is cyanide poisoning. That's it. Now coming to the fourth type, where the blood flow is actually decreased. Now let us consider the fourth type, doctors. We have a tissue with blood supply. Okay. Now for blood to reach this tissue, the blood needs to be pumped. Okay. So we need a cardiac pump to push the blood, to drive the blood to go to the tissues. Point number 1. Point number 2. As the force is being generated by the heart and as the blood is flowing through the blood vessel have to maintain the force and pressure to keep propelling the blood forward. Okay. So two mechanisms are inevitable and absolutely critical in taking the blood from the heart to the tissue. So you need effective cardiac contraction to push the blood into arterial circulation. Once the blood gets into arterial circulation, you need to maintain the pressure and force that is contributed by the minimal amount of vasoconstriction that keeps pushing the blood. Not to a serious constriction degree, I am telling, doctors. There is going to be a normal vascular tone which is in a state of minimal contraction, so that there is going to be a little bit of squeezing effect on the blood, so blood keeps moving forward. So this is how blood flow happens to a tissue. So 2 points, doctors, we just discussed about cardiac pump. Number 2, there is going to be a normal vasomotor tone. Number 2 is normal vasomotor tone. Now failure in cardiac contraction or problem in normal vascular tone this will lead to reduction in blood flow to tissues. So, we have failure in cardiac contraction, this is cardiac failure, and reduction in vasomotor tone happens during sepsis. In cardiac failure, there is going to be poor cardiac output. In sepsis, there is going to be distributive shock. Right, doctors, there is going to be a profound vasodilatation. Due to toxins released by those organisms because of endotoxemia, severe toxin levels in blood, there is going to be a profound vasodilatation. When blood vessels gets dilated, they cannot able to maintain the force essential to propel the blood forward. So when that force is reduced or taken off, the blood gets stagnated. Now this leads to stagnation of blood. As blood gets stagnated, the oxygen that is present in the blood does not reach the tissue level. Now, all these conditions will lead to a condition called as stagnant hypoxia. Right? These are the mechanisms, doctors. Let us summarize all the mechanisms. We will summarize from the last point we discussed. Let us start with stagnant hypoxia. Stagnant hypoxia is due to number 1, cardiac failure, number 2, sepsis. Now, cardiac failure is a circulatory collapse, sepsis is a distributive collapse. There is going to be a peripheral vasodilatation in sepsis, doctors, stagnant hypoxia. Right. Number 2, we discussed about cytotoxic hypoxia, where we saw the one condition, that is cyanide poisoning. Number 3, we discussed about anemic hypoxia, which is quite important, where we had number 1 conditions, anemia, reduction in hemoglobin, number 2, methemoglobinemia. We also have sulfhemoglobinemia, but most important regarding entrance exam is carbon monoxide poisoning. So, stagnant, cytotoxic and anemic hypoxia, doctors. Right. Now, in all the 3 conditions, let us keep hypoxemia in a reserve, because that needs to be discussed in a detailed way. So, in these 3 conditions, we have to look for a parameter called as alveolar arterial gradient. Alveolar arterial partial pressure of oxygen gradient. This states the difference between partial pressure of oxygen in alveolus and partial pressure of oxygen in pulmonary capillary. In arterial side, doctors, not on the venous side. Okay, once oxygenation happens, what is the partial pressure of oxygen on the arterial side? So we know on an average we have about 104 or 102 to 104 millimeters of mercury. On the arterial side, we have somewhat about on an average of 98 millimeters of mercury. So normal arterial gradient, the difference between oxygen partial pressure in alveolus and artery will be less than 10 millimeters of mercury, doctors. In spite of all the differences in physiological conditions, the normal alveolar arterial gradient should be less than 10 millimeters of mercury. This is normal alveolar arterial gradient. Right? Now, normal gradient, what does this tells you? This indicates partial pressure of alveolar oxygen is going to be normal, partial pressure of arterial oxygen is going to be normal. This indicates you have a perfectly functioning diffusion mechanism. A normal gradient indicates diffusion of oxygen from alveolus to arterial side. is normal. This is the one point you got to infer from alveolar arterial gradient, doctors. Fine. So let us consider the alveolar arterial gradient in these three conditions. Now remember, in stagnant hypoxia, arteries get enough oxygen from alveolus. There is no problem with diffusion. In cytotoxic hypoxia, again no problem with diffusion. In anemic hypoxia, again there is not going to be any problem with diffusion. Now please remember, in anemic hypoxia, the content is reduced. But what happens to partial pressure? Partial pressure is created by, you know that partial pressure is created by the dissolved form of oxygen, right? Dissolved form of oxygen is going to contribute to partial pressure. In anemic hypoxia, oxyhemoglobin is reduced because there is no hemoglobin, whereas dissolved form is going to be absolutely normal. So partial pressure are going to be very normal in anemic hypoxia. So my dear friends, in all the three conditions, stagnant, cytotoxic as well as anemic hypoxia, you do have normal alveolar arterial gradient, which means PaO2 minus P small a, arterial O2 is going to be less than 10 millimeters of mercury. Point number 1, and this needs to be very clearly understood, as well as you should never ever forget this. All these cases of hypoxia, stagnant, cytotoxic, anemic, will have normal alveolar arterial gradient, doctors. Now with completion of all these basic points, let us move on to discuss about the one very important topic, that is hypoxemia. The difference between the two words hypoxia and hypoxemia, by the time I guess you will be thorough in these two words. Let me recall that again for you guys. Hypoxia is reduction in tissue oxygen. Hypoxemia means reduced oxygen tension in blood. Reduced oxygen tension in blood, doctors. Okay. So what causes hypoxemia? So let me take you back to the basic concepts again. We have alveolus, pulmonary artery, pulmonary capillaries, and once pulmonary capillary gets oxygenated, they go for all these steps and they come into, the blood comes into arterial circulation. We'll keep it this way. Now the first and foremost point, you have atmosphere pressure of 760 millimeters of mercury. This is total pressure, and partial pressure of oxygen is going to be 149 millimeters of mercury. So from atmosphere, gas is going to enter into alveolus. Once gas enters the alveolus, it needs to be transported across the alveolar capillary membrane into pulmonary capillary. From pulmonary capillary, it has to reach arterial circulation. So three important steps, doctors. Let us take up one by one. Number 1, we have reduced oxygen availability in breathing air. Right? This is one very important point. When I say breathing air, it is not just room air, doctors. Patients who are on mechanical ventilation, who are intubated on a mechanical ventilation, if the fraction of inspired oxygen in the air coming from the ventilator falls, this is also gets considered as a reduction in oxygen availability of the inspired air. So it can be by any means. The subject can be inspiring room air, the subject can be inspiring gases coming from a ventilator, it doesn't matter. When the gas that is coming from any source, atmosphere or ventilator, if that gas do not have enough oxygen, the entry of those gas into the alveolus will bring less amount of oxygen, not of any sustainable levels. So this is the very first mechanism with which there is going to be reduced oxygen in alveolus itself, Because less oxygen is available in the alveolus, you do have reduced oxygen in artery. Okay. Now, because of decrement in oxygen in inspired air, there is going to be reduction in alveolar oxygen, reduction in pulmonary capillary oxygen, reduction in arterial oxygen. When arterial oxygen is also reduced, tissues also will reduce, will have less oxygen, leading to hypoxia. So, the conditions are seen in number 1, high altitude. As the subject climbs up, doctors, altitude much higher than mean sea level, the barometric pressure itself is less. Reduced barometric pressure means less amount of oxygen, and as the subject is inhaling less amount of oxygen in such an high altitude, he is going to suffer from hypoxemic hypoxia. Number 1 is high altitude. Number 2, as I just told you, in case of mechanically ventilated patient, reduced amount of fractional inspired oxygen. Right, doctors? If the subject is inhaling 100% gas, out of this, let us consider a room air for that matter. 100% room air has got 70% nitrogen, 21% oxygen. If you could able to recall our discussion, what we had on the video about gas transport, we have discussed everything in elaborate way, and I recommend, if you are getting stuck in this video, please have a primary visit and understanding of those videos first and revisit this video again, my dear friends. So, when the fraction of oxygen in the inspired gas is getting reduced, this can happen at, again, in high altitude and low oxygen from central supply. In case of mechanically ventilated patient, these two conditions will lead to hypoxia. The fourth condition, doctors, hypoxia. Hypoxia due to reduced arterial oxygen level. Point number 1, decreased availability of oxygen in breathing air. Let's move to the second condition. Now, the oxygen availability is absolutely fine, no problem at all. But what happens when the membrane is very thick? When there is going to be a thickening of membrane due to fibrosis, interstitial pneumonitis, conditions like that, because of thickened membrane, there is going to be a diffusion defect. Friends, the second important point in hypoxemic hypoxia is diffusion defect. Diffusion defect is seen in conditions like fibrosis, interstitial pneumonitis. When there is poor diffusion, there is going to be poor oxygenation. So, we have less diffusion, we do have less diffusion, less oxygenation in arterial circulation. Okay, that is second reason, diffusion defects. Now, friends, let us see the third condition. Let us take up V by Q mismatch. Ventilation perfusion mismatch, doctors. Right? When it comes to ventilation perfusion mismatch, we have a huge spectrum of disorders that are getting covered in this topic, ventilation perfusion mismatch. Let us take up the first condition, that is normal ventilation and zero perfusion, and there is going to be again a normal ventilation. Instead of complete absence of perfusion, there is a reduction in perfusion. And the third condition is reduced ventilation. Here ventilation is reduced, but we have normal perfusion. Blood supply to lungs are normal. On the other hand, there is going to be zero ventilation, absolutely zero ventilation, no ventilation, normal perfusion. So, V by Q mismatch spans across a wide spectrum of disorders, doctors. Now, when can we expect a normal ventilation but zero perfusion? This happens with massive pulmonary embolism. Massive pulmonary embolism leads to ventilation perfusion mismatch, isn't it? When the denominator becomes 0, we know V by Q ratio becomes infinite. So, this is an example for dead space. This is an example for dead space, doctors, right? So, let us keep this as condition number 1, right? There is going to be a massive pulmonary embolism and there is going to be dead space. Now, let us move on to discuss about the second condition where ventilation is going to be normal and perfusion is going to be reduced. This is seen in conditions like cardiac failure or pulmonary hypotension, right? Right ventricle has to pump blood to lungs. In conditions like cardiac failure or pulmonary hypotension, there is not going to be enough blood from right ventricle going to lungs. In these conditions, the perfusion is not going to be absolutely zero, but it will be much reduced. With a very little amount of blood supply to lung, the available oxygen will not be utilized, will not be diffused, or the RBCs in that little amount of blood is not going to harness enough oxygen from the alveolus. So, this leads to V by Q mismatch, doctors. On the other hand, ventilation is compromised while perfusion remains normal. Ventilation is compromised while perfusion remains normal. Blood supply is absolutely fine, doctors, but there is going to be poor ventilation. What are all the possible reasons? We have a lot of conditions. Number 1, bronchoconstriction, pneumonia, pneumonitis. We have segmental atelectasis, not massive atelectasis, but segmental atelectasis. Conditions that are not letting the lung to get expanded. For example, pneumothorax, massive pleural effusions. These are the conditions that stops air from getting into the alveolus. So, ventilation is going to be compromised, but perfusion is going to be more or less normal, doctors. So, again this will produce V by Q mismatch. And the last one, there is going to be zero ventilation but normal perfusion. This condition is seen in again atelectasis. This leads to V by Q ratio of 0. This leads to shunting, and this shunting is called as intrapulmonary shunt. Intrapulmonary shunting. Now, when it comes to intrapulmonary shunting, doctors, you have to be clear on one aspect. Number 1, when an alveolus is having enough oxygen in it, when partial pressure of alveolar oxygen is going to be normal, for example 104 millimeters of mercury, there is going to be a normal luminal patency of pulmonary arteries. But whenever these alveoli become underventilated, which means there is going to be a block in this alveoli, so this leads to partial pressure of oxygen to keep getting reduced. Till some degree, we do have normal opening of pulmonary vasculature, but because of less oxygen, the RBCs and plasma that are present in the pulmonary capillary do not get enough oxygen. Okay, the gas transfer will be inadequate. When this blood with inadequate oxygen, goes to pulmonary vein, which receives pulmonary capillaries from normal alveoli. The inadequately oxygenated blood is going to dilute the oxygen content from the normal alveoli blood vessels. Okay. So, for example, doctors, let us keep the partial pressure of oxygen in these blood vessels as the normal 102 millimeters of mercury, while this vessel has got a partial pressure of oxygen at just 70 millimeters of mercury because of less oxygenation. Now when these two blood get mixed, there is going to be reduction in partial pressure of oxygen in the total blood vessels. For example, let us take up these two blood vessels and they are combining together. Because of admixture of poorly oxygenated blood with the normal oxygenated blood, when poorly oxygenated blood combines with normally oxygenated blood, the vein that is being formed, pulmonary vein, will have partial pressure of oxygen neither 102 nor 70, it will be somewhat about 80 millimeters of mercury, because the normal oxygen levels will be compromised by reduced oxygen level in the inadequately oxygenated blood vessels, doctors. See, the point here is, because of block in alveolus, carbon dioxide also is not going to get eliminated. When there is no carbon dioxide elimination, carbon dioxide is going to retain in that particular blood vessel itself. Carbon dioxide is going to present in the main blood vessel itself. This presence of carbon dioxide contributes to a partial pressure that reduces partial pressure of other gases. So naturally, partial pressure of oxygen comes down to a somewhat little decreased. This is going to be a reduction in partial pressure of oxygen. This is called as intrapulmonary shunting. Right, doctors? Now, please understand this. When there is going to be intrapulmonary shunting, it means that alveoli are not getting enough oxygen. This happens to a certain degree. But when there is a severe reduction in alveolar oxygen content to the point of alveolar oxygen being less than 60 millimeters of mercury. Instead of 104, if the value falls down to 60 millimeters of mercury, this is nothing but a hypoxic environment, and this hypoxic environment in alveoli produces a reflex vasoconstriction. Vasoconstriction of pulmonary capillaries. Doctors, this is a protective mechanism, right? Normal lungs, normal pulmonary capillaries will be always in tune with the amount of oxygen available in the alveoli. When alveoli oxygen levels tremendously falls to a point of less than 60 millimeters of mercury, in that level of hypoxia, the pulmonary vasculature will not stay open and they go for immediate closure. This is called as pulmonary vasoconstriction induced by hypoxia, also called as hypoxic pulmonary vasoconstriction. Now, this is a protective mechanism. Number one, hypoxic pulmonary vasoconstriction. This is a protective mechanism, doctors, and most important point, the hypoxia induced vasoconstriction is seen only in pulmonary vasculature. Seen only in pulmonary vasculature. Rest everywhere, you take up every other organ. You take up brain, you take up liver, you take up heart. In every other major organs, whenever there is hypoxia, there is going to be a vasodilatation. Hypoxia produces vasodilatation everywhere except in lungs. Lungs, hypoxia causes vasoconstriction, doctors. Now, because of all these mechanisms, okay, we have ventilation perfusion mismatch. Because of ventilation perfusion mismatch, there is going to be less oxygen available in the arterial blood. This leads to arterial hypoxemia. So, point number one is decreased oxygen availability in breathing air. Number two, diffusion defect. Number three, ventilation perfusion mismatch. Let us move on to number 4 point, doctor. So, point number 4 is true shunt. which is also called as intracardiac shunt. Here, the oxygenation from alveolus to pulmonary capillary is absolutely fine. We have normal alveolus, normal pulmonary capillary. Oxygen transfer from alveolus to capillary is absolutely normal, as this blood goes to pulmonary vein and pulmonary vein goes to left atrium. As this goes to left ventricle, let us take up aorta here. Well, let us consider AV valves, mitral valve in this case. On right side we have right ventricle. There is a opening between right ventricle and left ventricle, doctors. Ventricular septal defects. Due to ventricular septal defects, we have deoxygenated blood from right side getting shunted to left side. So this leads to a right to left shunt. As we just discussed, whenever we get addition of a new gas into a blood, partial pressure of the existing gas reduces. So partial pressure of oxygen in left atrium is going to be about 100 millimeters of mercury. When it comes to left ventricle, again it is going to be 100 millimeters of mercury. Now, because of contamination of a carbon dioxide rich blood into left ventricle, the partial pressure of oxygen falls. Okay. So, when it comes to artery, instead of normal 98 millimeters of mercury partial pressure, we now have somewhat about 60 to 70 on an average. For an example, I am saying, doctors, partial pressure of arterial oxygen. So, this kind of hypoxemia because of true shunting is called as intracardiac shunting, and because of this hypoxemia, tissues also will suffer because of hypoxia. So, together, doctors, this is another reason for hypoxemic hypoxia. And the last point in hypoxemic hypoxia is alveolar hypoventilation. Alveolar hypoventilation, where you do have neuromuscular failure. See, we have central nervous system, in the sense we have respiratory centers in medulla oblongata. This respiratory center is going to excite thoracic muscles. This excitation happens by nerves, neurons. Respiratory excites thoracic muscle. When thoracic muscles moves, it moves the ribs also. So let us consider thoracic muscle, and because of thoracic muscle, ribs moves, so there is going to be a movement of thorax. On the whole, thorax is going to move. When thorax is going to get expanded, the intrathoracic pressure falls. This leads to entry of air through airways. Entry of air through airways into lungs, my dear friends. This is how neuromuscular event will lead to entry of air into lungs. We have lot of pathologies in this pathway consecutively leading to decreased air entry into the lungs. For example, let us consider CNS, respiratory centers, brain on the simpler level. Let us consider this as brain. Any stroke in brain, any infections, any tumors, any trauma, any poisonings, narcotics poisoning, opiates poisoning. So because of all these conditions, doctors, there is going to be a cerebral suppression. There is going to be a cerebral suppression as well as medullary suppression, leading to failure in respiratory center to get activated. So there is going to be a respiratory center failure. Because of that, ventilation becomes fail. When ventilation is not happening, air entry is not going to happen. This leads to alveolar hypoxemia. When it comes to nerves, we have certain condition that damages the nerve, that includes amyotrophic lateral sclerosis. Guillain-Barré syndrome, botulinum, botulinum toxin, the condition botulism. These are all the reasons with which nerves gets damaged, other neuropathies. When nerves gets damaged, they do not conduct the impulses generated from respiratory center to thoracic ribs and muscles, and this leads to neuromuscular failure. When thoracic ribs and muscles are involved by certain disorders, for example, myasthenia gravis of thoracic muscle, myasthenia gravis. Number 2, kyphoscoliosis, ribcage abnormality, morbid obesity, where respiratory muscle finds it very difficult to expand and collapse, okay, morbid obesity, and any kind of muscular disorders as well as skeletal muscle disorders. We'll bring this under one category, that is myopathies. Any tremendous restriction to rib cage movement, okay, even though ribs are moving, we do have certain conditions that does not allow the lungs to get expanded. So the thorax as such does not going to expand. Conditions like pneumothorax, massive pleural effusions, they are all going to restrict the movement of thorax. When thorax is not moving, air entry is going to be abnormal. Coming to airways, doctors, certain conditions affects airways, preventing air entry. Most important, laryngeal edema, vocal cord paralysis. These restricts or any obstruction, tumors, major obstructions, these restricts air entry into the airways, doctors. For example, COPDs. They produce obstruction, thereby preventing air entry into the airways, right? Now coming to lungs, conditions like fibrosis, pneumonitis, these are all conditions that restricts lung movement. So together all these conditions is going to prevent expansion of thorax. This is a neuromuscular failure culminating in a condition called as alveolar hypoventilation. So together all these conditions causes hypoxemia, doctors. So let us summarize everything so that you will have a complete revision of all. So the point is hypoxemic hypoxia. So in the last point, hypoxemic hypoxia, we are going to discuss about the conditions that causes hypoxemia. Number 1, reduced oxygen availability in breathing air. Number 2, diffusion defects. Number 3, V by Q mismatch. Okay, people. Number 4, we have true shunting, that is intracardiac shunting. And number 5, we have clear cut alveolar hypoventilation. These are the 5 reasons that contributes to hypoxemia. Because of hypoxemia, it leads to hypoxia, doctors. Fine. Now, how to differentiate and what is the another point you need to know in this condition? Again, we got to speak about the alveolar arterial gradient, and that is how your questions have been designed, doctors. Okay. So, likewise, we discussed the alveolar arterial gradient in other 3 forms of hypoxia. We also need to discuss alveolar arterial gradient for the fourth kind of hypoxia, that is hypoxemic hypoxia. So when it comes to that point, alveolar arterial oxygen gradient, in condition number 1, decreased availability of oxygen in breathing air. Entry itself is the problem, and that is the only problem, doctor. But the diffusion is going to happen in a very normal level. Whatever comes to alveolus will have a normal diffusion into pulmonary capillary. This makes the gradient to stay normal. Alveolus itself will have less oxygen. That less oxygen comes to blood vessels, so the gradient remains normal. So alveolar arterial gradient remains normal. Diffusion defect. The oxygen that gets into the alveoli is not getting into the blood vessel. So all the oxygen is going to stay in the alveoli itself, increasing the alveolar concentration of oxygen, reducing the arterial concentration of oxygen. So alveolar arterial gradient widens. Okay. So this leads to widened alveolar arterial gradient. Ventilation perfusion mismatch. In spite of oxygen, less oxygen coming to alveolus or less blood coming to take up the oxygen, there is going to be V by Q mismatch. In these conditions, this will be abnormal, doctors. Right? Coming to true shunting, alveolus will have normal oxygen, whereas because of cardiac problems, septal defects and all, there is going to be decreased oxygen in arteries. So arterial oxygen is much less, alveolar oxygen is much higher or on normal side. So together, true shunting leads to widening of alveolar arterial gradient. Coming to alveolar hypoventilation, because lungs are not moving, air is not getting into the lung, this is going to resemble somewhat like decreased oxygen availability. So here also less oxygen enters alveolus, and the whatever oxygen comes to alveolus will be taken to blood vessel. So here also alveolar arterial gradient remains normal. So alveolar arterial gradient is normal in two conditions of hypoxemic hypoxia, that is decreased oxygen availability in breathing air, and the second one is alveolar hypoventilation, doctors. Right? So this completes our first topic, hypoxia. Now here, when it comes to the point of oxygen therapy, oxygen therapy is needed in only one condition, whenever there is a reduction in arterial oxygen levels. The primary indication of oxygen therapy, the best and most important indication of oxygen therapy is reduction in arterial oxygen level, that is nothing but hypoxemic hypoxia. So oxygen therapy is applicable and useful only in hypoxic hypoxemia, not in other cases of hypoxia, doctors. So remember, oxygen therapy is applicable only in hypoxemic hypoxia. This oxygen therapy is applied in normal pressures.